I'm very happy to present our last presenter. It's Professor Peter Soyer. He's one of the most famous dermatologists in the world. Originally, he's from Austria, but he's living in Australia for a long, long time, and he is one of the leading dermatologists regarding 3D body scanner. And his presentation is titled "A 3D Total Body Images Research Network, the Australian Experiment." So I'm very glad that you're here today.
Okay, good evening, and Chris Scott. Thanks so much for inviting me to talk today. And I immediately go into my first slide, sharing my conflicts of interests. You all will know that Australia and Queensland in particular is dubbed the melanoma capital of the world. And unfortunately, we have the highest melanoma incidence worldwide. We see in Australia up to 13,000 melanoma each year and up to 28,000 in situ melanomas. And in my talk, I really would like to focus basically just on total body photography and then share with you a little bit our research network, which we have. We are in the process of building up. Total body photography was introduced into dermatology in around 1988 from L. Kopf, a former president of the American Academy of Dermatology and the director of the Pigmented Skin Lesion Clinic in New York University. And 10 years later, then it was brought to Australia by John Kelly, a dermatologist in Melbourne. But I really like to jump immediately into 3D total body imaging. And we have at our clinical research facility, actually we, not within the dermatology department, but within the clinical research facility, this 3D total body system now probably in our 4th year. And as you see, there is looks a little bit like a spaceship with 92 cameras. They are basically in boats with two cameras, and they are obviously precisely placed. And at the end of the day, when the images are shot at the same time, or slightly time difference of a couple of milliseconds, 92 images are shot, and then obviously a 3D total body avatar is constructed. This takes about 12 to 15 minutes. And we have just done a small publication a few years ago where we basically show that the image quality provides so-called pseudodermoscopy images. I mean, the middle column shows pictures of a lesion which has changed over time. In the right column, you see the dermoscopy, which is of course excellent, but still, despite the pixelation, you get an idea already with the 3D total body image, which has a pseudodermoscopy appearance. Just to share with you the workflow, and I was clicking a little bit too fast. The study participants get into the system and then goes into the so-called vector pose, where he has to hold the arm in a specific pose, and within a second, basically, all the 92 cameras are shooting. By the way, this gentleman is a former PhD student from us, colleague from Syria, who is now working at the University of California in San Francisco. And but with the 3D total body, we have just a total body image. And then, of course, if you want to have the individual dermoscopic images, this is actually quite time intensive, because The software is actually very nice. You have just to tip on the moles and do then the dermoscopic images. But and this can be done in the same room, can be done in another room. So this depends on the workflow which you like to integrate here. But let me show to you just two examples about, let's say, the strength of the system. And the strength is obviously the longitudinal component is one of the strengths of the system. So you see, this is a lady who had already a couple of melanomas, melanoma in situ, and then we were imaging this lesion. And because we were seeing her every 6 months, you see quite nicely that the lesion is slightly growing over time. And I think this, you can appreciate this already at the level of the total body imaging. And here again, now you have the individual dermoscopy, and then in the middle column, the basically pixelated pseudodermoscopy, which is basically just a magnification out of the total body image. This lesion was diagnosed as in situ melanoma. And the question, of course, is really, was this a melanoma already in February 2019 or in August 2019, or was this a benign nevus and then a dysplastic nevus? I mean, these questions are indeed very difficult to answer at this stage. And you will know that different colleagues, different pathologists, some of them are very opinionated about this approach. But let me share with you another example. And I think this is particularly interesting. This gentleman had a melanoma basically 20 years ago, but he has several moles. He is obviously very anxious. He sees a couple of doctors, and with us, he came in as a research participant. So we are not basically taking care of him from a medical point of view. And when I did then the lesion review with my younger colleagues, this lesion was brought to my attention. I was saying, what's the problem? This is absolutely benign nevus. In God's sake, maybe you like to call it benign dysplastic nevus. But then you will see with the total body images, you see quite clearly that this lesion is absolutely growing de novo. Yeah, in a gentleman at 46, there was 0 there. In 47, and you probably will not even see it in this red. It's a tiny, it's a tiny dot here. You see it, it's really tiny. And then basically 1 year later, it's a lesion with about 4 millimeter. And interestingly enough, there is already a so-called change module integrated, not validated, not FDA approved, nor DGA approved. And it's actually a bit cumbersome to work on it, but it shows quite clearly that all these moles in this frame, and you see if the lesion have changed when they're getting larger or darker, there is blue, otherwise they're yellow. And this change module goes on the clinical images. And obviously this lesion has clearly grown. And by the way, the system already at this stage basically counts automatically all moles. But and you see that this gentleman has quite a few moles, but you also see that the algorithm is more error prone when the person has more than 100 nevi or more than 50 seborrheic keratosis. The interesting aspect of this case is that this lesion was absolutely benign, right? The pathologist called it a dysplastic nevus with low-grade dysplasia. I'm pretty sure that some other pathologists would just call it a benign nevus. And I think what we are learning from this, and obviously many other cases, with the same features is that not every growing mole is a melanoma. Having said this, of course, at this moment we had to excise this lesion, not just because of the anxiety of the patient, but because we don't yet know too much about this growing nevi later in life. But let me now speak a little bit about our research framework, which we are building up. It was in end 2018, we and when I say we, this is a consortium of researchers from the University of Queensland, the University of Sydney and Monash, under the leadership of UQ. We got a 10 million infrastructure grant from the Australian Cancer Research Foundation. And in this slide, basically, this summarizes our research aims. Obviously, the mission is to transform melanoma early detection using total body surveillance to enhance individual lesion management. And we have three blocks of research. One is about diagnostic intelligence, and this is obviously integrating the clinical data, the historical data, the clinical phenotype with the genotype, and of course with the 3D total body images, with the dermoscopic images, and also with the pathology images. And we have already established a pathology working group. We have also established an AI working group in this context. For the hospital and health services is, of course, the HTR, the health technology assessment of uppermost relevance, to which extent, basically this is health economic, yeah? Improving costs for the patient and for the healthcare system. And this is a very challenging topic in its own right. And another big working block is about informatics, to integrate the total body imaging into the telehealth networks, into the PACS systems, into the electronic medical records, through implementation of image standards. And as an outcome, we have committed to build up the world's largest comprehensive skin imaging database, and obviously work on reliable solutions for melanoma early detection. And one of our big visions is to prepare the roadmap for a nationwide targeted screening program in Australia. And as you know, there are lots and pros and cons in this context. Just to share with you our team capability, it's an aspect we are particularly proud of. Of course, dermatologists are involved, but you see there are quite a few other specialties involved, from computational science to primary care, from pathology to health economic. Big arm, we have a consumer engagement, and of course, as you can see here, there's quite a big team capability across our three universities. And to complicate things further, as in Germany, where you have the different Bundesländer or region, however you call it, we have here the different states. So the three universities and three different states in Queensland, in New South Wales with Sydney, and in Victoria with Melbourne. And I can tell you, each of the states has specific regulations, and it's quite a bit of a nightmare. Having said this, there's a fantastic commitment from the e-health researchers at the university level, but also on the hospital level. And we were able to get quite a bit of in-kind support from our partners. And one of the big ideas is to get to start a melanoma cohort study. We have at this moment already started this. We have recruited, despite COVID in Queensland, now 500 patients. But the idea is obviously to include 15,000. And earlier this year, our key researcher from Monash, Victoria Ma, she got a significant grant from the Australian research body, more than $3 million. And basically, this is a cohort study. Everyone who is over 18 and has a GP will be included. And we are looking not just on very high and high-risk patients. Actually, we have a specific focus and low on average patients. And we have quite a few partner projects involved, as you can imagine. DICOM is, a colleague of us is basically leading, chairing the International DICOM Working Group for Dermatology. SERP stands for Security E-Research Platform under leadership of Monash. XNAT under leadership from Sydney is basically a very specific imaging platform, and so on. And as a consortium, we have also contributed to the ISIC Challenge, International Skin Imaging Challenge for Memorial Sloan Kettering. So it's a project which will keep us busy, hopefully for a few years, not to say decades. And we are quite proud that this will be the first of its kind network of 3D total body imaging systems, which will open the door for telemedicine and for AI-supported telemedicine. We are working on a comprehensive open access image repository, and obviously this will lead to disruptive solutions for the early detection of melanoma. At the end of my presentation, I just have a few slides related in what way will AI be integrated. And you know quite well that AI is now used not just in medicine, in oncology, in radiology, in ophthalmology, you name it. But basically from finances, it's basically taking over our life. And you see also that from mathematicians to computer scientists, there's so many different domains. But in our case, what we are contributing, we as dermatology, is our domain expertise. This is what our morphologic knowledge and obviously the integration with the pathology. And in this context, one can speculate how will the AI basically be integrated into the clinical workflow. Will it be an automatic second opinion, so that first we do our clinical assessment, and before we finish it, we do an AI analysis, which would be then obviously the pro, we would retain the current clinical work flow and is a beneficial for the sensitivity. On the other hand, if we would have automatic triage and we, the dermatologists, just see then the triaged lesion, so this would be, of course, a complete clinical paradigm shift. Let's say in the good and in the bad, there would be an over-reliance on AI, not to speak about regulatory issues, and it may lead to a de-skilling of the dermatology workforce. But of course, it will reduce assessment time, and it will highlight concerning lesions. So the verdict is obviously not yet out. And just one example. So this is a lesion in a gentleman over 60 on the lower leg, above the malleolus. And the other option is, of course, that the AI immediately kicks in. Yeah, you see the lesion, and you immediately see a confidence score. And to be honest, I did make this up completely. Yeah. But what do you do if the AI tells you 1% desmoplastic melanoma or 0.1% desmoplastic melanoma? Would you be then influenced? Would you excise it or not? I mean, in this case, I can tell you there's no pathology, but this is a lesion on my malleolus. I have it for probably 20 years. It doesn't change. It sometimes gets a little bit irritated. So, but this is just to show you an example. And I think the last slide is a little bit of a, let's say, of a joke and it's in a spaß. This is how I look at the patient without glasses. With glasses is the way how I look when the patient presents like this. And with augmented reality, I would probably see even the diagnosis on this screen and the percentage of the probability diagnosis. Of course, we are not yet there, and I was saying this is just a little bit of a joke how it could come up in a couple of years or in a couple of decades. It's open for the fantasy. So I like to close my presentation with sharing with you this this demoscopic image of a lesion, of a pigmented lesion, and I just ask you to make your diagnosis. Is this a benign nevus? Is this a dysplastic nevus? Or is this an unusual melanoma? The answer every so often is quite simple, right? By definition, this has to be a benign lesion because Australia is a pretty benign nation. So thank you so much, and thanks for your attention. And I'm very happy, of course, to have the discussion in German or English, however you like.
Yeah, thank you very much for this very interesting talk. It's quite nice. So we got a dry disease scanner like a few months ago, but we are really at the beginning of the research. So it's really interesting to see how it could work. And I have a question: do the dry disease scanner have the same accuracy also in Black people or Asian people, or is there different?
No, it will be a big difference. And actually, we have just got some funding for a sub-study of our cohort study. We will invite people with skin of color. We have quite a few Australians who are Asians. We have people from, how they call it here, the subcontinent, India, Pakistan, Sri Lanka, Bangladesh, and of course we have also people, Hispanic people from South America. And of course, indigenous population. Research with indigenous people has specific goals in Australia, and this is quite complex in its own right. But we definitely will focus on skin of color, and we know that melanomas are very rare, with the exception of the hand and foot. But moles very often are quite pigmented and would mimic a melanoma in a person, in a Caucasian, right, in a European. Mm-hmm. So this will be an interesting experience.
Okay. So, and can you guess how many people you will need to get the same accuracy?
You're speaking of the people of color, or in general?
Not in general, or like.
No, in general, we are planning to. We have committed to basically 15,000 persons, and obviously everyone with a ultra high risk of melanoma will be imaged 6 monthly for 3 years, but people with a low risk will just be imaged twice at baseline and 24. And I think the funding we have now for 5 years, but we are committed, and this will not be anymore myself, but team members are planning then to extend this to a 10-year cohort study. Yeah, and I mean, at the moment, obviously because of COVID, from these 15 systems, 5 are installed. Yeah. 2 in Victoria, and 2 in New South Wales, and 1 in Queensland, and 2 will now be installed in January, because at the moment not even no one is allowed from New South Wales to travel to Queensland, right? Mm-hmm. It's like if you wouldn't go from Baden-Württemberg to Bayern. This is strict border. It's not possible. But on the positive side, we have no COVID cases in Queensland yet, right? I mean, this is the positive side of the equation. But eventually we will have 15 sites across, as we call it, the Eastern Seaboard, and we will have a few sites on places where there is no dermatologist, where we'll basically test telemedicine. And there's a huge interest also from our funding body for for these regional and rural areas, because equity of access is a big issue in Australia. And of course, it's not as densely populated as Germany.